My guest tonight is Dr. Stephen Morse. He's professor of epidemiology at Columbia University Medical Center and director, infectious disease epidemiology. In 2000, he returned to Columbia after 4 years in government as program manager for biodefense at the Defense Advanced Research Project Agency, also known as DARPA, part of the U.S. Department of Defense, where he co-directed the Pathogen Countermeasures Program and subsequently directed the Advanced Diagnostics Program. Additionally, before coming to Columbia, he was assistant professor of virology at the Rockefeller University, where he's also an adjunct faculty member. His book, Emerging Viruses, was selected by American scientists for a list of 100 top science books of the 20th century. So tonight we're going to talk about monkeypox, and I just looked up the latest figures. So just bear with me while I find it. So, in May of this year, New York City identified its first case of monkeypox. There are now in the United States 13,517 total cases as of August 17th. New York State has 2,675. And New York City has 2,548. So at least in New York State, 98% of the cases are in New York City. So I thought we'd do a little primer. What is monkeypox?
Well, monkeypox is actually a pox virus related to smallpox, but as we know, not nearly as well adapted to humans. And it really lived out in the wilds in Central and West Africa. It was found in wildlife, and occasionally people would get it, very rarely. It was misnomer, actually. It was first identified in 1958 in a monkey, captive monkeys in a laboratory in Denmark. And that's how it got the name monkeypox. And then it was found later during that decade in other monkey, research monkey colonies. With the eradication of smallpox, this is an example of be careful what you wish for. So smallpox obviously was a major target for control and the only human infectious disease that we know of to have been eradicated due to human effort. The last case was in 1978. The last natural case of smallpox was in 1977, and in 1980, smallpox was officially declared extinct, or essentially no longer circulating in the human population. As the smallpox eradication progressed, the main tool for doing that was trying to find the cases, surveillance, and then vaccination. And the vaccine used, called vaccinia, which many of us who are old enough had when we were born and don't remember it, but still have the scars to show it, was very effective. It was effective enough that we could, in fact, or the WHO could, in fact, eradicate smallpox. The downside of that was that monkeypox, which had always been in the environment, in wildlife, probably rodents, was now able to be recognized. It came out from under the shadow of smallpox. And as fewer and fewer people had immunizations and were vaccinated or otherwise protected against smallpox, obviously we had more and more people also susceptible. In the past, there would be occasional cases reported. The first human case of monkeypox in humans, was in a child in it's now the Democratic Republic of the Congo in 1970. And there had been some sporadic cases after that. We actually had a very odd outbreak in 2003 in the pet trade in the US. And that turned out to be coming from rodents housed with of all things, if you watch John Oliver's show, you would know prairie dogs, which it turns out are susceptible, and they passed it along to their handlers, to veterinarians, to pet owners. Very mild monkeypox traditionally, historically, even the more severe Central African form, which we now call clade 1, clade is a branch of the family tree, is essentially may have 10% mortality untreated, but basically it does not spread well from person to person. The West African, which we first saw here in 2003 in that outbreak, but then first appeared in humans in Africa in an outbreak in Nigeria in 2017, which is still going on, it turns out to be milder, less transmissible, still, not very enjoyable to get. But that is really the unintended consequence of the fact that we eradicated smallpox and therefore no longer have, since 1972 or so, people who have immunity against the closely related viruses, smallpox, and its less human adapted relative monkeypox. It used to be pretty rare.
So it's not so rare now.
Yes, it took advantage of an opportunity to spread because it really isn't very transmissible. It really requires close skin or mucous membrane contact. There were some household cases that would occur in Africa, in endemic areas, all along essentially the southern coast of Africa. But basically, one of the classical things about monkeypox was that it didn't really sustain itself very well in the human population. Unlike smallpox, which had in fact become adapted to humans, so much so that we could eradicate it, and it's not out there anymore except, in collection somewhere. Nevertheless, monkeypox is still out there in wildlife, but smallpox was very well adapted to humans. It spread readily with a fairly high case fatality rate and fairly severe disease in many cases. Monkeypox is not well adapted, was not well adapted classically to humans. So it might infect members of a household in which somebody got infected. And it might go a few cycles of infection before burning out. Essentially, it would then just die out in the human population and couldn't transmit any further. We never really quite understood why, and we still don't understand why. So classically, this is the kind of thing that, irrespective of the numbers, after a few cycles of human-to-human transmission, you'd expect it to disappear. We don't know yet whether this is behaving the same way, that monkeypox. In every other way, it's behaving like classical West African clade 2, that is, monkeypox. It's mild compared with smallpox. That's not saying much. It's not that transmissible. It doesn't transmit much by the respiratory route, but it does transmit by very, very close skin contact with lesions or other skin or mucous membrane contact with somebody who has and is shedding the virus, usually from a lesion. I won't talk now about other fluids and so on, but I'm certainly happy to talk about that. What happened here was very much like what happened in the first days of HIV. Monkeypox, which was picked up probably by a traveler to Nigeria who picked it up there, where there, as I mentioned, there's an outbreak going on, but it's been endemic there, probably forever, only we didn't know that, came to the UK, and in early May was found to have monkeypox and had transmitted it within essentially his social network. So we're seeing it largely within certain, we would call them risk groups, men who have sex with men, LGBTQ, those who are bisexual or maybe gender fluid, And the reason that's happened is very much like HIV. The opportunity for this virus to spread, normally it would not spread that readily, but the opportunity to do it through intimate contact or close contact through these very wide and very mobile sexual and social networks made it possible for this virus to take advantage of it and spread. Normally we would just see a few sporadic cases. So that's what made this different in scale and scope.
So I also watched John Oliver.
Okay.
Show, and a few of the people who had monkeypox described it as being horrible, that they felt that, you know, they were completely broken out. They felt like someone was hitting them all the time, you know, injecting them. They were miserable.
Oh no, it's I won't minimize that. You know, it's not smallpox, but that's no consolation. You know, when you are comparing it to, you know, it's not the plague, but the reality is it can be a very painful disease, and you know, we would like obviously to prevent its additional further transmission and try to contain and control it now. Which should have been done in Nigeria probably in 2017, but no one was paying attention at the time, or the Western world with the resources was not yet paying attention. And hopefully there's still an opportunity to control it, but it can be extremely painful and last for weeks, because it takes weeks for it to heal. And often the incubation period is 1 to 2 weeks, and then it may be weeks to a month or more before people really heal. In the meantime, you know, especially if through some of the ways that people have contracted it, some of the anatomic locations, it can be extremely painful. And some people get it, you know, broken out with rash and swollen lymph node all over their body. Others may have just 1 or 2 lesions. They may not even know it, maybe inside the mouth. So it really varies a lot, but it's not unusual for it to be excruciatingly painful.
So for us who've had a smallpox vaccine, are we immune to it?
No, but you probably are getting some protection from it. So we used to think that smallpox vaccine, which I had when I was born, I still have the scar to prove it, so it proves I'm of a certain age. That scar, you know, it reminds me that I had that smallpox vaccine, which is neither smallpox nor monkeypox. It's another pox virus they're all fairly closely related. But it was thought at one time to be to give lifelong immunity. We now know that it doesn't in many people, probably most people, but it does give good immunity. And so people who have had it at birth or early life probably have some protection, but it really varies a lot depending on the individual. Better to have had it than not to have had it, since the majority of the population has never had a vaccine for smallpox.
So for those who have questions, please put them in the Q&A box, the chat box. So unlike COVID, when it first hit, there is a vaccine against monkeypox.
There are actually several vaccines against monkeypox, but they're all based on the same. They're essentially derivatives of the vaccine we got as children. But the one that we hear about the most, so-called GenEos, is a much more, it's a gentler strain that doesn't cause the side effects that you see with the traditional smallpox vaccine. That includes local lesions. This is a much milder, much gentler vaccine, which is why we're recommending it for people. On the other hand, the Japanese also have a similar vaccine, which they're keeping to themselves right now, but you can probably go and get it in Japan. What actually happened was that after smallpox was eradicated, there was a real concern with 9/11, after 9/11, that most people after 1972 or from 1972 on never got a smallpox vaccine. So they had no immunity. Most people have no immunity to smallpox. And there was a fear that maybe a terrorist or who knows what could somehow unleash smallpox on the world. And that would be really serious. And that was a scenario that people practiced for a lot after 9/11. And they stockpiled vaccine, but also HIV had not yet appeared by time smallpox was eradicated and declared eradicated in 1980. So it was recognized that it was really important. We didn't know what the traditional vaccine would do, and we had no real drugs for people who were immunocompromised, immunosuppressed. In those days, the early 1980s, there was no treatment, real effective treatment as we have today for HIV. So there was a concern to make sure that a vaccine was developed, and that's the one that you now know as the Bavarian Nordic GenEos vaccine in short supply, that would be give protection and be more user friendly, but give protection to people who might have impaired immune systems. And there's so many now with cancer chemotherapy and so many and so many other immunosuppressive situations. A drug was also developed. That's the one that you that's now known as Tecoviroma or Tpox, developed by a company called SIGA, and there's a whole story there which I won't go into now. And that has never really been used on a large scale, but it's been used in a few cases where somebody happened to get a pox virus, cowpox, believe it or not, which is of course a rodent virus, actually gets into human beings from time to time, and needs to be treated. It can cause disease that can be noticeable, and others, monkeypox in Africa. So it was used in those cases, and safety trials were done, and it does seem to work quite well. Although this is the first time we're able to, it's possible, unfortunately, to be able to test it on a large number of infected human beings.
All right, so I'm going to take some questions that have come in. We already answered how do you catch monkeypox and how is it spreading. How is monkeypox treated once you have it? And how do you treat the sores and scabs on the body that we have seen on TV?
It really depends to some extent on how badly somebody is affected, but if Tecoviroma Tpox is sufficiently available, and I think that is one area in which I would say, the authorities nationally and internationally could have done better on assuring a supply. And I won't get into it, but I think FDA could have risen to the occasion more effectively than they have, because the drug is already approved for use in smallpox. Now, admittedly, smallpox is, often is fatal often enough that you're willing to take chances, but safety trials show that Tecoviroma Tpox seems like a safe drug. At least comparable to other drugs like antibiotics and antivirals that we use quite regularly. And the anecdotal information I've heard so far from people running trials on it, such as at New York Presbyterian Columbia Medical Center, are saying that it does seem safe and effective. So for people who are really sick and have symptoms, they could get Tecoviroma Tpox if it's available. And there are a few places, I don't want to advertise Columbia because they'll be deluged with requests, but they're able to get some, and really we should be giving it to a lot of reproductive health clinics, adolescent health clinics, and places that are used to dealing with the populations who might be most at risk and have it more widely available. But we're not at that stage yet. There's not a supply issue there. It's partly an issue of getting the bureaucratic approvals, frankly. But that can be used, and it does seem to, although we don't have much data, it does seem clearly to shorten the course of disease, although we don't yet have enough data to know. If you can catch it early, if you can find it, if someone has been infected and they go and seek medical attention earlier on, within the first few days before usually they get symptoms, they could still take the vaccine, the GenEos vaccine. And that's thought to probably prevent the expression of symptoms, or at least, make them very much milder. And of course, the first line of defense is always prevention. If people know how it's transmitted, they can decide what actions they want to take to prevent their own exposure to it. That becomes more of a personal matter, especially within the communities where we're seeing it most frequently. But, this is not officially a sexually transmitted disease, but I think of its transmission as very much resembling, let's say, herpes simplex, which is type 2, is thought to be, is classified as a sexually transmitted disease. This is not. It just happens to take advantage of the same transmission mechanisms, basically close, usually prolonged and abrasive contact with a source of the virus, usually a lesion from an infected person. They may or may not be aware of it. Sometimes an intimate article, some personal article, but that's less frequent. And then sometimes within household settings, but that again, occurs often enough or rarely enough that we see it reported in the press when it happens. And they're usually, we know it happens in Africa. It's happened in some cases here, but that's not the most frequent. So people in the higher risk groups who are most likely to be exposed to it, certainly they should know whom they're close with. This does not spread readily. In fact, it probably infinitesimally spreads by casual contact. So people don't get it by, standing up at parties or going to the theater or going to work or going on the subway. It takes much closer contact than that. And so, if someone thinks they have monkeypox, they should obviously seek medical attention, go to their healthcare provider. There are a number of possibilities. If they have symptoms, they can be treated. The recommendation has been to treat the symptomatic manifestations, the pain especially, just because there hasn't been enough availability of the drug. But I hope that will improve. And for those who think they are at risk of exposure or may have actually been exposed by close contact with an individual who had monkeypox or had contact with someone who had monkeypox, obviously the vaccine is very much sought after. There's been a lot of complaint in New York City about how hard it is to get the vaccine. And it's not really the city's fault so much as the fact that there simply wasn't a sufficient supply, which shows how hard it is, even though we were extremely concerned about smallpox preparedness after 9/11. 20 years later, a lot of that has obviously not been sustained.
So I know the CDC has a recommendation, or the Biden administration, that in order to get more people vaccinated, they have a 5-dose intradermal vaccination method.
Yeah, what happened actually was that, and if anyone, I can talk about that. The GenEos, because it's considered more user-friendly, and therefore, in technical terms, these are all live attenuated vaccinia virus, attenuated, weakened. However, the GenEos is non-replicating. It's a variety of vaccinia that is milder and does not replicate, does not actually reproduce within the body, unlike the traditional vaccine. So it is much gentler for that reason. The side effects are more like your ordinary vaccine side effects, at the injection site, and so on. But the company that makes it in Denmark, Bavarian Nordic, is a very small company. And they made a big batch initially, which was stored over here, but that was years ago. And they have limited capacity to manufacture. There were some other unfortunate coincidences that conspired with bad timing. So there was limited capacity and we didn't know how much we would need. So probably we should have ordered more to be sent over here. And then, as I mentioned, there were some bureaucratic hurdles, but they're trying to speed that up. This requires 2 doses normally because it's thought of like the vaccines we've been using for COVID. Essentially, it's a gentler vaccine, but you may need 2 doses to get the full effect. So we initially sort of pulled back and said, well, 1 dose is better than none. And then there had been some experiments in the past at National Institutes of Health, some studies that had shown that you could dilute this vaccine by 1 to 5, maybe even 1 to 10, but 1 to 5 is what they used, and then giving it intradermally, which is just under the skin instead of, just under the superficial layers of skin. Those of you who are old enough to remember, when I was a kid, we used tuberculin tests to tell if someone had tuberculosis. And I ran away from many of them, but they don't hurt at all, I later discovered. It's about the least painless injection most painless injection you can imagine. It does take some skill to do it. The vaccine itself otherwise is normally given under the skin in the arm. This can be given in the forearm, just between layers of skin. And it turns out that it's more immunogenic. It gets a better immune response that way. We did that some years ago with yellow fever vaccine, not related, of course, but there was a shortage of that. So, people try to find ways around the shortage when there's a supply shortage. My general feeling is that this is better than none at all. So until we get a better supply, probably I think this will work. It does take a little more skill to do it, but anyone who's old enough has done this to do tuberculin tests. And it's a lot easier than giving the traditional vaccine, which requires the traditional bifurcated needle and is a real ritual. And maybe that was part of the charm. This vaccine, the GenEos vaccine, is much easier to give, but even intradermally at reduced doses with some practice, I think, someone who is used to giving injections can learn to do it fairly easily.
So the TB test was not a vaccine. It was like a 4-pronged thing that you watch to see if it turn red.
That was the time test, which came in later in my childhood, and they would stick it. No, the tuberculin test is an antigen. So basically what they're looking for is a T cell response, an immune response to the tuberculosis or related antigen. And in the old days, when I was growing up, so I'm 70, they used to give it intradermally under the skin. And so people who are old enough remember that. Then they found an easier way to do it. Now we in most places use different tests entirely. But it turned out that it could be done by pediatricians on a large scale, 50 or 60 years ago, before easier ways were found to do these. And people who take allergy tests are probably getting it the same way, because the tuberculin test is basically a kind of test of the immune response using the antigen.
So in 1988, there was a TB outbreak in New York City, and all school children had to get TB tests. And much to my daughter's horror, she had to get the Mantoux test.
That's an old one.
More
Yeah.
invasive. And she was saying to me bitterly about what a terrible father I was making her do this.
Yeah. Well, the TB story is a very interesting one, because Tom Frieden, who was our city health commissioner, is now doing other things, and then went on to become director of CDC, actually had worked for the CDC in India, trying to get their TB problem under control. And then when we had this problem in the 70s and 80s, he came back here to repeat essentially the same success. And did, it's still very much with us, and especially we worry about drug resistance in TB, but it's a lot better than it was, as you know. We now have other tests that don't require injecting anything. You take blood and you can test this by the immune response in blood.
As we know, every child loves getting blood tests.
Yeah, well, we I don't know which is the lesser of the two evils. I guess you have to ask each child what they prefer, but we've all given up blood for the cause as well as other things.
So here's a question from actually a friend in high school.
Oh.
It says, so we went through similar experiences. It seems we are seeing throughout the world the rise of many viruses, some new such as COVID and others, such as polio, that were discovered many years ago. Do you have any theories as to why? And polio has been discovered in wastewater in New York City and Rockland County and Hudson County.
Yes, and also, by the way, in London last month. So they were worried about it. Yeah, it's ironic because there was a successful eradication of smallpox, and that emboldened some people to think that maybe there were a few others, notably measles, which is extremely transmissible and can be very nasty. I'm old enough to have actually had it before there was a vaccine. And of course, polio, where we have the tools and the model from the smallpox eradication, that perhaps we could do something similar, which is a very ambitious idea. Actually, you may remember a few years ago, in the same community, we had an outbreak of measles. And that's because there are some people in the country who believe that they shouldn't have their children vaccinated. I don't know if they like being or dislike being called anti-vaxxers, but in any case, there are a variety of people. Some are religious groups or sects of other religious groups. Some are just highly affluent people who don't understand that this was once a big problem. And so we do see outbreaks of measles and other vaccine preventable diseases in these under-vaccinated pockets of society. So in the case of measles, we thought we had it almost eliminated, except for a couple of pockets in Pakistan and Afghanistan. And there was still some circulating polio in a few other places. This, as you know, polio infects the gut. It's an enterovirus. And most people, certainly most children, don't actually show any symptoms of disease, but every so often, for reasons we're still debating, maybe 1 in 100 or 1 in 200 does, and then you see paralytic polio. So it always worries people, because if you see one case, there are probably many other infections out there. What we think happened in this case was someone who was traveling, got in contact in an area where they're still giving the live polio vaccine, which can revert and then get into an under-vaccinated population. And in some cases, it gives immunity, but that Sabin vaccine, the live vaccine, can also cause polio if it reverts. And it does eventually when it circulates, because people get it. It infects, the vaccine is in the gut. It gives very good protection. But, of course, people who are vaccinated with or immunized with the live virus polio vaccine, are still shedding virus from the gut asymptomatically. They're protected from disease, but if the vaccine virus reverts to being more like real wild type polio virus, and this is what we're seeing, then other people can catch it. And that's probably what happened here. He brought it back, and he's in a community where I think it's the same community where we saw measles a few years ago. So it's just a group of people who don't believe in vaccination. And so it's spread within that community. And of course, we find it in those who are under vaccinated, and we find it worldwide. in that situation, but usually most people are vaccinated, so it's very sporadic. And that will probably be true here. So if you ever had a polio vaccine, you probably have nothing to worry about. We in this country give the inactivated, the original Salk vaccine, because of this danger of what we call vaccine-derived paralytic polio from the live virus vaccine. But in other parts of the world, they still give the live vaccine because it's so much easier to give, you know, just a drop on the tongue. When I was a kid, I got it on a sugar cube, but I had both the Salk, I was kind of a guinea pig, and later the Sabin vaccine. We don't use the live virus vaccine in this country because the Western Hemisphere was declared polio free in the early 1990s. And so this is kind of a blot on our perfect record. But you know, if enough people are vaccinated, it will essentially not be a threat to any except those in the immediate vicinity who are not vaccinated. But it's a reminder that these things are still with us.
So now, you know, in the beginning of the COVID, when the vaccines were coming out, people were spending hours and hours and hours on the internet trying to make an appointment. Now you can just walk in and get a vaccine. So here's my, you know, it's not hard to get a vaccine. You can do it. It's, you know, they have too many people are not getting their boosters. So I have a question. If in an ideal world, if we had enough monkeypox vaccine, would everybody be getting it at a certain age, or?
That's a very hard question to answer because normally monkeypox is a pretty rare disease. This is an extremely unusual situation. And one thing that obviously we don't know is monkeypox, as I mentioned, is not really well adapted to humans historically. Did something different happen in Nigeria to allow them to have an ongoing outbreak in humans with several hundred cases a year from 2017 on, and now it's come here. So one speculation, and it's only speculation because we don't have the data, is that maybe it's better adapted to humans and therefore could spread better person to person than what we historically think of as monkeypox. We haven't seen the virus change in other ways. People report all kinds of mutations, but I don't, you know, unless you see some difference in the way the virus actually behaves, this is a pretty stable virus. The mutations are, you know, we don't have this level of detail, so everybody oohs and ahs, but the reality is we don't know what that means. If it spreads within large numbers of people, just as with the concern about COVID variants, although this is much more slowly evolving, it's a much more stable virus, still, with enough human-to-human transmission and enough people, it's possible that some variant will evolve that is better adapted to humans. It's possible, but we really don't know. But that's one concern and one reason we want to try to control it as soon as we can. The other concern is that, you know, normally it would burn itself out by now, and maybe it just, you know, hasn't burned itself out yet. But we obviously don't want to give it the opportunity to become better adapted to humans if it hasn't already. If it becomes well adapted to humans, we may very well be thinking about reintroducing a vaccine like GenEos that's not, you know, that's basically fairly mild, you know, not much more strenuous, to use the word of our former president, than the flu vaccine or several of the others. Right now, there really isn't any reason, because although it's normally quite rare and doesn't spread very well from person to person, the most of the people we see infected just happen to have the unfortunate circumstance that what they're doing, their social networks and so on, are providing an opportunity for a virus that doesn't normally spread very well, something like what we saw with HIV. But you know, so for most people, the risk of monkeypox is very small, and certainly with casual contacts. But you know, if it gets out of control, this will become much more frequent. So we do want to control it now. If it became endemic in the human population, the way we talk about COVID, then we might think about giving this vaccine more widely. Right now, there's no reason to, because most people are not at risk. Besides, the reality is we don't have enough vaccine to go around, which is why it's ironic. In the beginning, there's never enough vaccine, and then when there is enough vaccine, nobody wants it. So that's what happened with the COVID vaccine for SARS coronavirus 2 infection, and yet that was a miraculous vaccine that we kind of squandered that miracle if we'd been able to give it out a lot earlier. I do want to remind you all that you all know that COVID is SARS coronavirus 2 is still very much with us. And although I know we're all tired of it, and even though this is ostensibly a milder variant, the BA.5 right now, and who knows what comes next, but sort of the Omicron family. Nevertheless, it still does, in fact, it spreads very readily, very different from monkeypox. It spreads, like the flu, only much, much better, and it's still a risk for all of us. So we still need to take those precautions, because the chances of being infected with the SARS coronavirus 2, and even we see 36,000 hospitalizations a day now, even with this so-called milder, because it spreads so widely, it's still a risk. So we still have to remember that. And that's still a much greater threat for the moment, and hopefully for the foreseeable future, than monkeypox.
So I wanted to address a few myths. I go to physical therapists. A friend of mine said, "Don't stop going." And I said, "Why should I stop going?" He said, "Well," he said, "the person's touching you." I said, "Yes." And I said, "Okay." And he was on monkeypox. He said, "But how do you know that the person he's treated before, or the 5 people he treated, whatever, has monkeypox?" And to me, that's a very low, that doesn't make any sense.
Yeah, I think there's a very, very low probability. For one thing, some of the things we got conditioned to do, which may or may not have been important for SARS coronavirus 2 and COVID, but were good habits. We're, like washing your hands. So, that would take care of that. But you really have to have the virus being produced somewhere in order to be able for someone to become infected. So that means there's a lesion if you just happen, and there's an incubation period of several days. And there's still some argument, can people infect others while they're still incubating the virus before they show symptoms? That's unclear. Generally speaking, probably not. That we had that discussion with COVID, and we know the answer now. But yes, but here it's much harder. So your physical therapist, even if they don't wash their hands, and just let's hope they do, and just work on someone with monkeypox, is not going to be a threat. The virus is very stable, but we've seen very few, like smallpox. We've seen very few situations where it's spread extensively by inanimate objects. It has happened. That's usually required close contact and sharing of intimate objects. It can happen, but it's not that frequent. So, the getting it from somebody who touched a monkeypox person, even if they touch the lesion, I think the risk is very small.
Has the U.S. military still been vaccinating service members against smallpox?
Yes, by and large, yes, and that's not a secret. We're still worried, obviously, about it. And I myself, because of the fact that when I was working at DARPA, we actually had, this was in the old days, I guess, in the 1990s, we actually had scientific collaborations with the former Soviet Union. And one of the 2 legal repositories, official repositories of smallpox, is in now Siberia. It used to be in Moscow, but I think it's a lot better in Siberia, where there are fewer people. And they have the capabilities, obviously, of working on it under very, very strict circumstances, because you can't do experiments with smallpox. You require permission from the World Health Organization. you have to have your protocol approved. And there are only two places in the world where it can legally be done: the CDC in Atlanta and the Vector lab in Koltsovo near Novosibirsk, Siberia. And we used to go and work with them, not on weapons, but on trying to do things to help make the world safer. And so I got revaccinated a number of times with the old-fashioned vaccine, because the other ones didn't yet exist. The military, just in case some countries that we don't fully have a window into, you can guess what some of them are, may have some smallpox that they haven't told us about, and may at some point choose to use it. We hope not, but it's better to be safe in that situation. So not everyone in the military, but it's one of the generally fairly routine.
Is there any way to get tested for monkeypox without seeing a doctor?
Not yet. They'll probably be developing home tests. It's probably best, however, to seek medical attention if you think you have some risk, because, in fact, I think our testing system should be better. I mean, the way we do it now is the New York City Public Health Lab and some better clinical laboratories, Stanford, for example, several in New York in the academic centers, could actually test for it. But it's not official until the CDC blesses either the FDA blesses your test, or the CDC. This is what happened with SARS coronavirus 2, the COVID virus, as you remember, or the CDC confirms your result. That can take days. So, I think we should have more rapid testing turnaround. I think you saw even on John Oliver's show or other shows, people who were interviewed who said, by the time I got my positive result back, I was already, essentially over the infection, but I knew, but it was positive. So I knew it had been monkeypox. Well, thank you. But this is why you should go to your healthcare provider, because if they can take a test, hopefully they can get one with a more rapid turnaround. They can begin, keeping an eye on you and giving you any necessary care, which may be vaccination if they can get it early on, may be symptomatic, or the Tpox specific antiviral later on for those who are really feeling the effects. And the sooner you get a result, the better. But that's been one of the slow steps. It simply, could be done faster, but it's kind of specialized. And I used to be a great defender of the FDA, and in many ways I still am. But I think in the last couple of pandemics, it's clear that they're just, I'm really sorry to say this, but I'll say this, they're just not able to maintain the necessary agility. They do have to safeguard people's health and well-being. They have to make sure that vaccines and drugs are safe and effective, but sometimes they go a little far, and the end result is then they overcompensate, as they did with tests for the SARS coronavirus 2, the COVID virus. So I think they should really, and I think they are speeding things up. We are getting more vaccine in more quickly. It's being distributed after some initial problems that I know you've read about more quickly, and we hope that this will get into the pipeline. So I won't point fingers, there's enough blame to go around, but a home test, then you still have to see your healthcare provider if you're positive, and we can't guarantee that a test will be completely reliable. So if someone thinks they might have it, they should go and seek appropriate attention from a healthcare provider.
So can you open up the Q&A box?
Sure.
There's a question from the anonymous attendee about the COVID-19 study, and I don't quite understand this question. And
oh yeah, well, I mean, the reality is, yeah. So you're asking about variants of SARS coronavirus 2, or the COVID-19 virus. The terminology is very confusing, and unfortunately no one's made any effort to straighten it out, because I think the some of the powers that be, certainly in the previous administration, sorry to say, liked it that way. And there are other countries that, like to confuse us. So it's sometimes hard to get good data. There are actually a number of variants of SARS coronavirus 2. There are many more than we hear about, but many of them never really rise to prominence. They get outcompeted. That's really what it is, a Darwinian natural selection process of the fastest variant, the one that, so far it's been the one that transmits the best, wins the race and beats the others out. So, several have done that. Delta did that, before that Alpha, which was the UK variant, but our vaccine was tested with that in the UK, so we know that it works. Delta, which it works, the vaccine works to some degree very well against, but Omicron is a little different, and that's the next one to rise to real prominence. But there are really a lot of different variants within that family. So you've heard about BA.2, BA.4, BA.5. BA.5 is predominant now, but there are a lot of others. So you will find, once you get to that level of detail, that there are a lot of variants out there that don't get reported because nobody really tests at that level of detail. And they report it, it's all on the web. You can find it in NextStrain or in one of the other databases like GISAID, which has all these strains, but until they're reported, we don't know about them. And then when we see one that seems to be rising to prominence, taking off, not like the dud firework, but like a real rocket, then we begin to get worried. And that's what's happened with some of the Omicron variants, as one has replaced the other.
So as you know, England has given approval to I believe Moderna's bivalent vaccine, which will have the traditional vaccine plus a special Omicron. I believe the European Union has done it. So in the United States has been presented data by Moderna and Pfizer. So do you see in the fall will we be getting a new COVID vaccine?
I'm hopeful. The other thing is that, of course, this, if this were the last variant or the last group of variants that we ever saw, I would feel much better about it. But the fact is, that it still has the capacity to generate new variants. Even, Omicron was from a different branch, if you will, of the SARS coronavirus 2 family tree, or a different, twig or twigs off a different branch. So whatever metaphor you prefer to, in my case, torture. But, the reality is that was unexpected. It was different from the others we'd seen, which had sort of been following a path, going down sort of the main line, and this was off to the side. Will the next big variant continue to be, one improved, if you will, new and improved, better transmitting Omicron variant replacing another? Or will it be something entirely different, or going back to something that's different enough that the vaccine no longer covers it? We don't know. So I think we should at least make sure we're covered with this one. And so that's the idea behind making the Omicron specific or Omicron targeted, in addition to the traditional one, to give broader coverage. And it will give broader coverage. There is a lot of talk about giving pan-coronavirus, or much more broadly reactive, broad spectrum vaccines, which would cover a broader range of coronavirus, SARS coronavirus 2 variants, and might give us better assurance in the future. But until then, I still recommend the vaccine is great. We should all take it. I hope in the fall we'll have one that's better targeted to what we're seeing now, but we don't know what we'll be seeing in the fall. We're always trying to play catch up with these. So, I'm waiting for that new one. but hopefully there won't be a new variant by then as well. That's why we all have to cut down the transmission of these viruses, because that's really, it's all these other measures, the masking and other things, boring as they are, the other precautions with close contact precautions with monkeypox that, can prevent spreading this infection. And the more people are able to do it, and the better people are able to do it, the better chance we have of slowing this down and emerging from it. Probably this will be another endemic coronavirus. We have 4 that cause common colds, and we never really thought about them very much until now. This may be a 5th one, but that's the end stage, I think. We may not get there this year. I just don't know. With monkeypox, we also don't know, but I'm hopeful that it, will remain essentially like the classic clade 2 West African. And although it's spread widely, still remain controllable and remain within, not go out to the entire population. So far, it's just not that easy to catch, but unfortunately, under the right conditions, it is possible. But I wouldn't worry about getting it on the subway. The possibility of the coronavirus on the subway still exists.
Okay, well, why don't we end there on that hopeful note? And I want to thank Dr. Morse for spending time with us. And this is our last broadcast until after Labor Day. And we'll be talking in September about exercise and other areas of interest. And we'll probably do some more on the next COVID vaccine.
Okay, well, no doubt, because I see a couple of questions about that. Yeah, Evusheld, I know is, this is for the coronavirus, is underutilized. So far, it's actually recommended. As of now, it still seems to work pretty well, but many people don't know about it. Someone said their question wasn't about the variants that circulate that we haven't, really paid much attention to, but the immune system hampering as a result of the vaccine. I won't, if you forgive me, not answer that question now. I think that we will learn a lot more as we go forward. So far, I haven't seen a lot of evidence as opposed to monoclonal antibodies, but where you do get selection for resistance, less so with vaccines, but I don't know that we have enough data. So I really, at this point, don't think I can answer your question honestly, and so I won't try. Thank you for asking, though. It's a great question. Thank you for all the great questions.
Oh, thank you again for spending time with us. And everyone, enjoy the last few weeks of summer and stay safe, wear a mask, even though I don't see many people wearing them anymore, but you can stay safe. Okay, take care.
Thank you.
You're welcome. Good night.
Pleasure as always. Good to see you all, even if I can't see you. My very best to everybody.
Well, hopefully
stay safe.
Hopefully one day we'll be doing these in person again.
Oh, I hope so. Again, yes. Stay safe and sane. And it's okay to be on the subway, but remember, COVID is still with us. So.
Okay.
Okay. Thank you.
Good night.